Welcome to the LDN radio show, brought to you by the LDN Research Trust. I'm your host, Linda Elseygood. I have an exciting lineup of guest speakers who are LDN experts in their field. We will be discussing low-dose Naltrexone and its many uses in autoimmune diseases, cancers, etc. You're invited to join us on air, asking your questions by calling in on the local rate phone numbers in the UK and the US, which can be found on ldnradio.org. Thank you for joining us. Today our guest is Dr. Ginevra Liptan, who's from the Frida Center in Oregon in the US, and she specialises in fibromyalgia. Learn more about Dr. Liptan's successful integrative treatment approach to fibromyalgia in her book, The Fibro Manual, a complete fibromyalgia treatment guide for you and your doctor, available online from Amazon. It includes key guidance for your doctor so that they can help you more effectively, clinic website www.fridacenter.com, or phone 503 206 6220. Thank you for joining us today, Dr. Ginevra Liptan. We're really pleased to have you with us.
Thank you for having me.
First of all, I know our listeners are very inquisitive and they would like to know who you are. Could you tell us how you got into medicine, what your story is?
Sure. Well, I got into medicine because I had some health problems in college that I really couldn't figure out what to do from a Western medicine perspective. Nothing was helpful. And when I worked with a naturopath, I got benefit. And so I thought I wanted to go into medicine to really do integrative medicine, kind of pulling best of both alternative and Western medicine approaches together. And then when I was in medical school, the universe helped me to figure out what illness I would be specializing in by giving me fibromyalgia myself. So I spent a good bit of time in medical school trying to figure out why I was having so much muscle pain and fatigue and brain fog. And at first I just thought it was from stress and saw lots of doctors, and they couldn't really help me to figure out what was going on. Finally, I had to really figure it out for myself, and ultimately got a diagnosis of fibromyalgia, took some time off from medical school, was my own guinea pig trying to find effective treatments, and then I cobbled together enough treatments to kind of get myself back to medical school, and then since then I've really devoted my entire career to researching fibromyalgia, trying to treat it using anything that's effective, whether it's Western, alternative, crystals. I don't care what it is. If it helps and there's data behind it, I will apply it and see how it does in the clinic. And what I realized as I went forward is that a lot of doctors really don't know. They still don't quite know how to treat fibromyalgia. So I wrote a book trying to help kind of download what I've learned over the past 20 years about fibromyalgia, both what people can do for themselves and then what their doctors need to do. So that's my story.
Okay, let's do one thing at a time. Let's start with you in your practice. If a patient came to you showing signs of fibromyalgia, how would you go about treating that patient? What examination, what tests would you do?
You mean as far as kind of the diagnosis part or more the treatment part? Because
both.
I can definitely address both.
Yes, if they came in a lot of pain and hadn't had a diagnosis, how would you go about, diagnosing?
So generally what I'm looking for to make a diagnosis of fibromyalgia is really muscle pain. That's kind of the thing that distinguishes distinguishes it from other types of chronic pain conditions is that it's really the soft tissue, the muscles that are very, very tender, and kind of the widespread pain in the muscles is what we see with fibromyalgia. So, number one, I'll ask people and have them do a pain diagram kind of showing where they're hurting. And then I'll do a physical exam where I press on areas of their muscle. And fibromyalgia patients tend to be very tender in certain specific muscle areas. And so kind of right our upper trapezius, right above our gluteus, along kind of our outer thighs, we tend to be exquisitely tender. So if somebody has muscle tenderness, they're tender in enough of those places when I press on them, and they're also complaining of fatigue and brain fog, that combination is enough to diagnose someone with fibromyalgia. When I'm doing lab tests, I'm really looking to exclude any other conditions that could be mimicking fibromyalgia. Very severe hypothyroidism can mimic fibromyalgia. Sometimes you have to rule out things like MS or lupus or other rheumatoid rheumatologic conditions. So labs, I'm usually trying to exclude other things, and then the diagnosis is really based on that pattern of symptoms and tenderness on exam.
Mm-hmm. And then how do you go about treating? The treatment part, that is a much more complex part. So that's why I had to write a whole book about treatment, because it's so you have to really personalize it to exactly what's going on with the person. Mm-hmm. But I will say that the 4 things that I work on with patients is, number one, improving the quality of their sleep. People with fibromyalgia are not getting into that deep, restful sleep, and that's where our muscles do most of their repair and regeneration. So I work with both kind of natural treatments and then pharmaceuticals to help restore deep quality sleep. So that's kind of number one. Number 2 is trying to improve the health and function of our muscles themselves. The areas that are so tight and painful, they tend to get quite inflamed and can develop trigger points that are really tender, painful knots of tissue. And so I work with both kind of manual therapies, certain types of massage to help release some of that tightness in the muscles, along with training patients to do their own kind of muscle relaxation, whether that's kind of more meditation or hypnosis-based, or doing gentle stretching. So kind of muscle self-care, and then doing some treatment trigger point injections can be very helpful to break up those painful trigger points. And then the third component of fibromyalgia treatment is trying to reduce systemic inflammation in the body. So working on trying to help calm down the body-wide inflammation. And that can be with diet changes, kind of changing to a diet that has less inflammatory substances in it. And for many people, those can be some of the tastier foods, gluten and dairy and high sugar. So kind of trying to make some diet changes to reduce inflammation, using supplements and other treatments to reduce inflammation. And then the hormone balance in fibromyalgia can get really thrown out of whack, so making sure to kind of do everything I can to restore, improve hormone balance. And then finally, trying to reduce symptoms. And this is where things like our friend low-dose Naltrexone come in, because in fibromyalgia we know that the brain has some excess inflammation. And that inflammation is really what leads to the hypersensitivity to pain. So if we can help calm down the brain cells, and so there's less inflammation in the brain, guess what? Pain levels go down. So low-dose Naltrexone comes into my treatment approach after I've already helped people try and restore deep sleep, trying to work on the health of their muscles, reduce systemic inflammation. And then if people are still having a lot of
pain hypersensitivity, and that really is sort of the exaggerated pain response, meaning something that someone else would rate as maybe a 2 out of 10 pain level. People with fibromyalgia will rate the exact same amount of pressure. They'll rate it as an 8 out of 10. So what I've found low-dose naltrexone to be helpful for is trying to turn down the volume of that pain signaling.
Mm-hmm. And you have this whole plan in the chapters in your book, so people can actually buy the book and read all the details.
Yeah, and I tried to divide it into both things and each chapter ends with things people can do for themselves, because there's a lot that we can do to take care of ourselves with fibromyalgia. But then there's also some things that people might need their doctor's help with. So I tried to kind of divide it into those two things based on kind of what I call the 4 R's, which are kind of those 4 steps I talked about. So rest, repair, rebalance, and then finally reducing symptoms. But there's a lot we can do for ourselves, and then there's really some things that we need doctors and healthcare providers to help us with. But unfortunately, if they don't know about it, they can't help.
Exactly.
I felt like a big part of my mission was saying, hey, I know you're busy. I know that healthcare providers in general are very busy, but here's this interesting data about, let's say low-dose naltrexone, or about using turmeric extracts to reduce inflammation and to reduce pain. And it was sort of shocking to me how, and I'm sure you've seen this a lot with low-dose naltrexone, it's really shocking to me how, even though there is data out there and studies that have been done about these treatments, that doctors don't know about it. It sort of just boggles my mind. So I realized that the only way that we could really educate providers globally was patient by patient. And so that if patients say, hey, I read in this book about low-dose naltrexone, here, look is the reference. Would you look up this study, and would you be willing to prescribe it for me? I realized that it had to be sort of a grassroots kind of approach, and I think that's exactly what you've also been doing with the low-dose naltrexone organization, and all the good work you guys do is kind of just getting the message out to patients and also to providers. But really, I mean, correct me if I'm wrong, it sounds like kind of you're more trying to make sure that people are well educated and can bring that information to their healthcare providers.
That's right. We've been very fortunate the last few years. We've had so many doctors contact us asking for details of other prescribers that they can contact who prescribe for a certain condition. So the momentum is growing within the medical community. Yes.
Excellent.
I know,
and I think that networking is really important.
It is. It certainly is. And I know it's difficult. I've been on it myself, and I still am, on the gluten, dairy and sugar-free, and it's not easy to start with. It's not impossible. And we had nutritionist Jill Brook on the show, and she was explaining how your taste buds only live for 2 weeks. So if you go without your sugar, your cravings will stop because your taste buds will be re-educated not to crave those sugars. Do any of your patients report difficulties in changing their diets?
I wish I knew that taste bud fact before we just spoke, because that would have been so helpful for me trying to convince patients to make the change. I think people find it very hard and overwhelming to make those changes at first. Mm-hmm. But then once they're in the momentum of it and they start to feel better, it's it's kind of a self-fulfilling prophecy, because if you feel awful when you eat ice cream, it's really not very motivating to eat ice cream. Right. Mm-hmm. But trying to kind of get over that initial hurdle is really hard. And then you have to add into that the fact that most fibromyalgia patients, when they come to see me, they are so tired and exhausted and painful that just the very idea of going to the grocery store, chopping vegetables, sounds so impossibly overwhelming that they just can't even think about doing it. So a lot of what I've had to do is develop strategies to kind of help people make those changes in a in a kind of the easiest way possible. And I'm actually excited. I'm going to have a holistic nutritional counselor joining my practice soon, which I think will make that even more helpful to kind of develop those life tricks, sneaky ways to maybe, think about making cooking more easy and kind of quick substitutes for gluten. But yeah, it's a hard sell, but then once people start feeling better, they don't have a problem keeping it up. That's what I've found.
And the difficult thing to start with is if you buy anything from the shop that isn't fresh, it has gluten in, it would seem. There are so few items on a shelf that you can buy over here that are gluten-free. So you have to read the labels very carefully. And of course, once you've been in every chain of supermarkets, you then know, yes, I've bought that before. That doesn't have gluten in, but I can't buy this one. So your range is limited and it's usually more expensive, but you get into the swing of it. But to start with, it took us an awful long time to do the shopping when you were trying to find things that were gluten-free. But it does get easier. And
Absolutely.
as I say, your taste buds change and you don't have the cravings. It's not that difficult once you get used to it.
It's true, but you do have to be quite the label detective in the beginning, don't you?
Oh, yeah, you certainly do. And and sugar gets in everything as well, doesn't it? It's a difficult one.
It does.
So
it really is. And when you're in pain, you want comfort. You want sugar.
Exactly. It's comfort food, isn't it? All the nice things, lots of fat, lots of salt, lots of sugar.
Right.
Not good for you. So other than the diet and obviously dairy as well, supplement wise, I know that everybody's individual and you wouldn't recommend the same supplements for everybody across the board. But what would you say are the most common supplements that you give to your fibromyalgia patients?
Well, I try to be pretty mindful of the fact that it's hard. It's pretty overwhelming to keep up with a complicated and expensive supplement regimen. I mean, I can barely keep up with just taking 3 or 4 supplements a day. That's kind of my max. So what I've tried to do is I've tried to figure out what are the most important supplements in general for people with fibromyalgia. And those really fall into the category of those supplements that help improve and sustain good nervous system function. So that's both peripheral nerves, the spinal cord nerves, and then those nerves in our brain. And the ones that really do that tend to be things like the fish oils and the healthy omega fats, good quality activated B vitamins, so a good quality B complex, vitamin D, and then for some people, if there's if they need even a little bit of additional support, I like things like CoQ10, which are sort of general antioxidants and things that support mitochondrial function, so kind of supporting that part of our cells that help to make energy. So really kind of fish oil, B vitamins, vitamin D, and then sometimes some more focused nerve support with CoQ10. Those are the ones that I have found to be the most important. And then, of course, kind of adjusting that based on particular symptoms. If somebody's having a lot of pain that I think is stemming from inflammation, for example, joint pain, then I will usually try and add something in that's an herbal anti-inflammatory. And usually I use turmeric or extracts of turmeric or similar type herbal anti-inflammatories. So boswellia, devil's claw. So sometimes additional herbal anti-inflammatories. And then if people are having issues with sleep, I really like magnesium as a bedtime supplement because it's a very calming supplement, and many of us with fibromyalgia tend to be magnesium deficient. Our nervous system kind of churns through magnesium, so the more we can kind of replace, and kind of help our brain and body to get in that kind of calm, relaxed place in the evenings. That will help with sleep quality. So magnesium for sleep, and then kind of basic neuron support for other supplements. But I try to be sort of a minimalist with supplements just because I don't want to overwhelm either my patient's ability to take them or their pocketbook, because it can get quite expensive if you're taking a very, if you're taking 10, 20 supplements, they can get pretty expensive. And I don't want people to be taking things that are maybe not giving them much benefit, but are just costing them money that I would rather have them be using on something like some other kind of self-care, whether that's massage therapy. There's a certain form of massage therapy that I love for fibromyalgia, and I would much rather have people spend money on that than on 20 additional supplements that they might not need.
Sensible advice, I would say. Well, we're going to have a break. And we'll come back and we'll start answering some questions. If anybody would like to call in and ask Dr. Liptan the questions yourself, you can go to the website www.ldnradio.org, and it gives you the local rate call-in numbers for the US and the UK. We'll be back in just a minute. To listen to individual radio shows and interviews, go to www.mixcloud.com/LDNRT. I'll repeat that. It's www.mixcloud.com/LDNRT. Learn more about Dr. Liptan's successful integrative treatment approach to fibromyalgia in her book, The Fibro Manual, a complete fibromyalgia treatment guide for you and your doctor, available online from Amazon. It includes key guidance for your doctor so that they can help you more effectively, clinic website www.fridacentre.com, or phone 503 206 6220. Welcome back. So that was really interesting in the first part there. We learnt a lot from you. I'd just like to ask you a few callers' questions. We've got a lady called Amy, and she has fibromyalgia and has had problems with candida. She says, 3 years ago, I had a huge gastric candida infection, and I'm not sure if this caused my fibromyalgia or if I got an infection due to low immunity caused by the fibromyalgia. She treated the infection and takes probiotics daily, and she's very careful what she eats, and it's never returned. She's keen to try LDN, but has concerns that the candida will return. Is it likely to happen? And if so, when LDN is supposed to support your immune system? Could you answer that question for us, please?
Yes, that's an excellent question. I actually get asked that a lot.
Do you?
So,
good.
Yes. So many people with fibromyalgia do suffer with candida overgrowth. So we all have some candida living in and on us. Normally our immune system keeps that in check, and other healthy bacteria also keep that in check. With fibromyalgia, because we tend to be sleep deprived, we're not getting the deep sleep, our nervous system tends to be more in the fight or flight or kind of danger mode. Both of those things really suppress our immune system. So that puts us at higher risk of developing actually lots of types of infection, but the one that really seems to move in the most is the candida overgrowth issues. And often our gut is a big reservoir for candida. If people have a lot of sinus infections, recurrent sinus congestion, issues like that, that can also be an area of our body where we can get candida overgrowth. we often think of sinus infections being caused by bacteria, but you can also get a chronic picture that looks like chronic sinusitis, but really coming from candida overgrowth. So in answer to the first part of her question, generally what I see is that people will develop fibromyalgia and then secondarily will have a candida overgrowth type picture. And then unfortunately when you have candida overgrowth in the gut, that actually, the candida secretes extra toxins that make us even more tired and even more foggy and increase our pain. So it sort of magnifies the already present fibromyalgia symptoms. So she did all the right things, it sounds like, with diet and kind of probiotics and treating, getting rid of that candida infection. And then now she's wondering, if I take low-dose naltrexone, will that put me at a higher risk of a recurrence of candida? Mm-hmm. And she's absolutely right to be worried about that, because low-dose naltrexone, part of how it works, at least part of how we kind of when we look at globally how it's working, is it does work to kind of calm down certain parts of the immune system. And in particular, it's really looking, for fibromyalgia, we've looked at the glial cells in the brain and know that it can calm down those particular immune cells that live in the brain and help them so that they're not over-responsive. Now, could that happen systemically? Could low-dose naltrexone affect other parts of our immune system and maybe make it so we're not able to mount as much of a response to candida? That's kind of the theoretical concern. And while in theory that could happen, what I've seen clinically is as long as people have already kind of addressed and are already kind of continuing things to keep their candida issues in check, if you add the low-dose naltrexone, it doesn't generally cause any issues as far as allowing that candida infection to kind of come back. I've had one patient that we did not realize that she had a candida issue, so she was not having any, doing any treatment for that. And then when we added low-dose naltrexone, it did seem to worsen her candida issue. But I've had plenty of patients that have had candida issues in the past, and when we added low-dose naltrexone, they did not suffer any ill effects as far as a recurrence of candida. So that's kind of a long way of saying, as long as she is kind of maintaining those things that she's doing as far as reducing sugars in her diet, keeping the probiotics, and there actually are some antifungal herbs that you can do to kind of add in if you're worried about it. I think she would be just fine to try low-dose naltrexone. But that's a really good question.
Good, and I'm sure Amy will be very satisfied with your answer there. It's a very good answer, thank you. And we have another question from a lady called Jo, and she says, a few months ago I started on LDN for fibromyalgia, and she also has chronic fatigue syndrome, so she started really low. Over a few months she increased the dose just because she couldn't face the fatigue and the viral infection feeling she had. But it did help with her bone pain. I stopped for a bit and the pain went through the roof. She started back on 0.5, but she says that she needs a higher dose because the fatigue is so overwhelming. Her GP knows nothing about LDN and she can't get back into the pain clinic for 3 months. She says she doesn't know what fillers her pharmacy use, and she also says that she's a nurse. Any help or advice would be appreciated.
So I want to make sure I understand this. When she originally took the low-dose naltrexone, she found benefit for pain, but it made fatigue worse? Is that what I understood?
Yes. She's saying when she increased, the fatigue and the viral infection feeling felt worse, but it helped with her bone pain. So she went back on the lower dose, but she said that she needs a higher dose for the pain. But then she gets the overwhelming fatigue again. So I mean,
okay. That's it's tricky, and what's challenging here, and hopefully this will be better in the future, is I think because many providers don't have the training or expertise in low-dose naltrexone, that it's hard to then have them help make dosage adjustments. So ideally, in a perfect world situation, she would maybe be able to do some incremental increases, really if she's on 0.5 going up to 0.6, 0.65, really slow incremental increases with her provider. That would be my first suggestion. The other question I would have for her is every once in a while I'll have people that they get benefit from the low-dose naltrexone for pain, but it does seem to cause sometimes some sleep interference. And as I've talked about, the sleep issues in fibromyalgia are pretty key. So clinically, I'll see that every once in a while, people that are, if low-dose naltrexone, if they're taking it at night and it's interfering with their sleep, sometimes they will do better if we move it to the morning. And the two fibromyalgia studies that were done with low-dose naltrexone by the group at Stanford, both of those did show reduction in pain. They were sort of neutral on fatigue. The first study showed a little improvement in fatigue. The second one showed no benefit for fatigue. But in both of those studies, people did complain. A few of the kind of study participants had some insomnia or vivid dreams or kind of sleep interference. And so I would suggest to her, if she's not tried tweaking the timing, perhaps moving it away from nighttime hours to see if it could lessen any sleep interference. Because if it's causing any sleep interference, that's definitely going to make fatigue worse. That would be my other suggestion.
Mm-hmm. Wonderful. Thank you. So that was Joe's question. We have a question from Melanie. She has fibromyalgia, interstitial cystitis, and anxiety. Her question is, how long do I have to be off opiates or gabapentin before I use LDN?
Okay. So I'm going to address those separately because the opiates and the LDN is a whole bag of worms. So I'll address that separately. The gabapentin issue, so I've always been a bit confused by this because I get asked that a lot on my blog. I get a lot of questions saying, I've heard I can't take LDN plus gabapentin. What should I do? And I personally prescribe those two medications together all the time, and they work on different mechanisms in the brain. The low-dose naltrexone is trying to calm down the activity in the glial cells, calm down those immune cells in the brain, and that's how it works on pain. Whereas gabapentin is slowing down the nerve transmission, both in the brain and in the spinal cord, and that's how it works on pain. So because usually when you have two medicines that are working on different mechanisms, they are usually, there's exceptions, but usually safe to combine. So maybe you can enlighten me, Linda. I'm not sure why I get asked so much about the gabapentin and low-dose naltrexone, unless there may be data out there that I'm not aware of. But I, in a clinical setting, combine them all the time with no problem. So
yes,
do you know anything about that?
Many doctors do prescribe gabapentin with LDN and have no adverse effects. Like you said, it's just the opiates that you have to be careful of.
That was my understanding, but I was wondering if there was like something I had missed in there because I wasn't. But I've not had any problem with it, and I think they work on different mechanisms, and I think they actually combine pretty well together and can be a nice. They can give some adjunctive, additional support. Mm. Now, the opiates and low-dose naltrexone, that is a dilemma wrapped in a quagmire because here's what I found. I have found for some people, if you use an ultra-low dose of naltrexone, meaning usually that's 0.5 milligrams or less, and you separate it out by 6 hours or so from your opiate dosage, as long as it's a short-acting opiate. So let's say you take a morphine, you take it at noon, and then you take your low-dose naltrexone at 9 p.m., theoretically, the morphine would be out of your system enough that the low-dose naltrexone should not interact too much, particularly if it's a low dose, ultra low dose of the naltrexone. That's the theory, but in reality, unfortunately, what I found is that even if you're separating it by time, and even if you have the ultra low dose form of LDN, that people can still get some withdrawal feelings when they take the LDN. So kind of the opiate withdrawal, sweating, and nauseated, and kind of feeling awful. So to get around that, what we've kind of said is, you need to not combine low-dose naltrexone with opiates. And so a lot of people taper off and then want to know how long do they have to be off an opiate before they could add in low-dose naltrexone. And I think really somewhere around the 2-week range is probably the safest place to where you could start it. But I have had people start it as quickly as a week after they've come off an opiate and done just fine. It has not seemed to induce any type of withdrawal. That's the biggest, from my practice, that's the biggest limitation to using low-dose naltrexone, is that by the time people come to see me as a specialty fibromyalgia clinician, over half of my patients that come to see me that walk in the door are already on opiates, and sometimes quite a high dose of them. Mm-hmm. So it limits somewhat my ability to prescribe low-dose naltrexone as much as I would like. And as much as I've tried to convince people to experiment and do the ultra-low-dose naltrexone protocol with me and just separate it in time, people understandably are very cautious about anything that might either make their opiates less effective for pain relief or might induce withdrawal-type symptoms. So I think probably a week being off would be fine, 2 weeks if she wanted to be really, really cautious. And I feel like that combination of ultra-low-dose naltrexone and opiates needs to be studied more systematically because many people in pain are taking some sort of opiate, and I really wish that it didn't have to be an either-or. Either you took an opiate or you took low-dose naltrexone. I wish that there was some more data out there about if there are any effective or safe ways to combine it or what the right dosage schedule might be. I'm hoping to learn some of that at the conference in September because that's the area that I feel like from a clinical perspective, dealing with people in pain every day, I want to be able to know, I would love to have things to offer people that are still on opiates because it can be a pretty overwhelming proposition to try and taper off something that is helping their pain.
It's a tricky one, isn't it?
It really is. It really is.
Certainly is. We've got another question just come in here from Carrie, and she says, could LDN help with both pain and the fatigue syndromes, and how long should I take it for? The LDN, that is.
Yeah, LDN can absolutely help with pain. The 2 studies at Stanford showed about a 30% reduction in pain in 2/3 of the patients that took the LDN these are fibromyalgia patients. And that's actually better than almost any pharmaceutical we have available right now as far as data. So absolutely, pain benefits. Usually I see people getting the most pain benefit right around day 28, and that's pretty consistent with what the studies have shown as well. So around 3 to 4 weeks is where you kind of start to get the most benefit, but people will get some benefit usually within the week or 2, but, we're increasing the dosage slowly over that time. I've had a few patients that do feel like it has helped with fatigue for them. Those tend to be folks that already have a pretty good sleep program in place, that we've already worked on some of the other things as far as diet. I've had a few patients that have both chronic fatigue syndrome and fibromyalgia, and they did feel like they got some benefit from both the pain of fibromyalgia and also the fatigue component that we were attributing to the chronic fatigue syndrome. So I usually encourage people to take it for about a month before they decide whether it's going to be helpful for them. And in my clinic, I've found it's pretty consistent with what the Stanford study showed, that about 2/3 of the patients I prescribe LDN to get pain benefit from. And I've had some patients that get a really substantial pain benefit. We're talking like 60% pain reduction. So, I mean, that's just dramatic. It can be life-changing. Usually people are more in the kind of 30 to 40% range. But if you combine low-dose naltrexone with sleep improvement, with manual therapy that's working on the muscles and to kind of help release the tension, that tightness that we have in our fibromyalgia muscles, that's where I see people getting the most benefit, where if you're not just doing LDN kind of isolated, but you're also doing it as part of a kind of a comprehensive fibromyalgia treatment approach. So I would encourage her, if she's not doing other things, to also try and look at some of those other important pieces that she could maybe pull in as she tries to kind of get ready to add the LDN in.
Mm-hmm. And I think what she was asking as well is, how long does she have to take the LDN for?
Oh, I see. Most people I've started on it want to continue it, so have continued it indefinitely. I do know that in the Stanford studies, once they stopped it, I think they were about 12 weeks, something like that. After they stopped it, people did have some residual benefit afterwards. You know, they looked at them a month after the study had ended, something like that, and they still had some pain benefit. So it's possible that she could take it for, let's say, 3 months, 6 months, 9 months, and then stop it and have some ongoing residual benefit. But honestly, when people get benefit from it, they want to just keep taking it. So most of my patients have just kind of been taking it ongoing.
Mm-hmm. Thank you.
But she could certainly, I'm definitely for people, experimenting. She could be a guinea pig and figure out if a shorter term, and then stop it if she gets residual benefits. Tell her I want to know.
Okay, we'll do. We'll just have another quick break and we'll be back in a moment. The LDN 2017 conference will be held in Portland, Oregon, in the US, 22nd to the 24th of September. If you are unable to attend in person, we'll bring the conference to you, regardless where you live. You can participate via our live stream. Check out www.ldn2017.com for early bird discounts. The conference will examine life-changing breakthroughs for treating multiple sclerosis, Crohn's disease, colitis, autism, irritable bowel syndrome, lupus, fibromyalgia, rheumatoid arthritis, chronic pain, mental health issues, restless leg syndrome, and many other conditions using low-dose naltrexone. For tickets, live stream, and sponsorship opportunities, go to www.ldn2017.com. Learn more about Dr. Liptan's successful integrative treatment approach to fibromyalgia in her book, The Fibro Manual, a complete fibromyalgia treatment guide for you and your doctor, available online from Amazon. It includes key guidance for your doctor so that they can help you more effectively, clinic website www.fridacentre.com, or phone 503 206 6220. Welcome back. We have a really interesting question here from George. He's been taking LDN for 2 years for fibromyalgia and CFS, and he says now that his symptoms have stabilised completely and he's feeling healthy and well. Now, his question is he would like to have a social drink maybe once or twice a week. He's on 5.5 milligrams of LDN. And would you consider 2 medium strength beers at a time to be okay to take with LDN?
A man after my own heart there. Let's see. Well, so that is a very good question. I know that theoretically there can be some interference with low-dose naltrexone, and the same way low-dose naltrexone can block opiate effectiveness, it can have the same with alcohol, and possibly vice versa. So the idea is if you add in alcohol, that it might make the low-dose naltrexone less effective. I certainly think, a little bit of alcohol in moderation, as long as it doesn't seem to flare his symptoms, would be perfectly fine. But again, I think that would be one where he'd have to kind of experiment, maybe starting with a small amount, half a beer or something like that, and then seeing kind of how he felt. I certainly think that with the lower doses of naltrexone, when we think about the higher doses of naltrexone, when you use it as 50 milligrams, it was designed actually, and part of how we use it in the U.S., maybe in the U.K. as well, is to treat alcohol addiction. So we use it to really block the effects of alcohol. So with the low-dose naltrexone, that's kind of a different beast, and I doubt that they have done a study where they've kind of seen how alcohol interferes with LDN. Although, Linda, maybe you would know about it. Have they done any studies looking at that? I'm not familiar with any.
Yeah. Claudia Christian uses Naltrexone in 50 milligram tablets. We've had her at a couple of conferences where people take one 50 milligrams 2 hours before they go out drinking, and it has no effect on them. Naltrexone blocks
the
it,
alcohol effect.
so that they don't feel any problems. Personally, I'm getting older, so one glass of wine, if I'm going out and I have one glass of wine, I really enjoy it, but I feel I really don't want any more after one. No bad reaction or anything, but that just feels that was enough. I enjoyed it and it was very nice. Thank you very much, but I really don't need any more. But George sent a follow-on while you were answering his question. Before he started on LDN, he wasn't going out. He was too tired and in too much pain. And he now feels so good that he wants to socialise again. So that's an improvement for him, isn't it?
Well, that in itself is wonderful. That is probably the best endorsement that I could possibly ask for low-dose naltrexone. And I'm so pleased that he found something that helped him in that way. And I would say that's the whole point of trying to feel better, is to live life, So I would say go for it, but maybe just try seeing how you do with a lower amount. Maybe one beer would be plenty, and I would just have him experiment. I guess I'm kind of an advocate for people, in safe ways, being their own guinea pig and learning their own body and their own responses, because everybody reacts so differently. That's the one thing I've really learned dealing with fibromyalgia patients over the years, is that what works for patient A is not necessarily going to work for patient B, but we know in general some things that tend to work for folks. So I think that George can study George and figure out if how he does a little bit of beer in moderation, and I'm so pleased that he feels better.
And the big thing is, when you have any chronic condition, and especially when you have a lot of pain and you're fatigued, it's very hard to socialise, isn't it? Because you don't feel well enough to make the effort to get ready to go out, or if you do make the effort, by the time you're ready to go out, you're too tired to go, or you feel pretty miserable and just wait to come home.
Right. I have so many patients that don't even want to make plans because they feel so bad about having to cancel plans repeatedly, because that's probably the most crazy-making thing about fibromyalgia and other chronic conditions. I know MS can be like this as well, is that, on Wednesday you might feel pretty okay. On Thursday you might feel awful. You just can't predict the fluctuations, and that can make socializing really hard. And then I see so many patients that just retreat into their homes. And then, of course, we're social creatures. When we don't have that interaction, we get depressed. And when we're depressed, guess what it does to pain? It makes pain worse. And then our pain is worse, so we get more depressed. And it's just this awful spiral that really has to be stopped somewhere. You have to kind of stop it. And I think that's actually the beautiful thing that I found about low-dose naltrexone is that that's one of the few things that I can really say to people, this could dramatically, with just this one intervention, really reduce your pain. It doesn't work for everybody. It doesn't work exactly the same for everybody. But the odds are pretty good. 60% patients respond to it in my clinic, and studies back that up. So that can make a huge difference. And then if people are feeling better, and then they can do more activity, and then maybe actually do that exercise that their doctor has been telling them to do, which is ludicrous to tell somebody to do when they feel so awful they can't leave the house. But if people start to feel a little bit better, then I see people can really incorporate some gentle exercise, some things that are enjoyable and can kind of help them to sustain and do better as they age. But when you're just in that stuck place where you are feeling as if you have the worst flu of your life all the time, how can you possibly get out and do anything? Socialize, exercise, work. I mean, that's where this illness can be so heartbreaking and really hard to take care of. And I think that's why I am one of the few people to. There's not very many fibromyalgia specialists in the world, and I think part of it is because it's a complicated illness that, as of yet, we don't have a silver bullet. I think low-dose naltrexone is probably the closest that we might have that could kind of fit in that category as far as one intervention that can help a lot of people. But a lot of times you have to do a really kind of trial and error, try this, do that, try this. Oh, that makes things worse, try this. So that I do a lot of the art of medicine, backing it up with the science, but that kind of trial and error piece can take a lot of time.
So in your book, do you talk about exercise at all?
I do, although I ban people from using the word exercise, and instead I replace it with the word gentle movement or gentle therapeutic movement. Because when we think of exercise, we think of sort of people doing an aerobics or a jazzercise class, for 45 minutes or going for a jog, and that is not at all what I'm talking about for fibromyalgia. So I advocate, and I have a chapter in my book dedicated to ways to incorporate gentle therapeutic movement into your life, always making sure you do a really good warm-up, doing some very low-impact things, and then doing a really good cool-down, and maybe just doing it incrementally. I mean, we're talking maybe 5 minutes to start, and then very slowly building up. And I feel like when exercise is used that way, it can actually be very helpful for fibromyalgia. But if you just go out and do what I tried to do in medical school, so I was diagnosed with fibromyalgia, my doctor told me the very helpful advice to go exercise, and probably I was depressed, and that was what was causing it. I tried to exercise, and I tried to go in the pool and do laps, and I thought that was very gentle, and I ended up spraining my neck and hurting myself, and I could barely move for weeks after I tried just exercising once. And I thought to myself, okay, I'm never going to do that again. And I think that happens to so many fibromyalgia patients is they do what they think they're supposed to for exercise, and it ends up causing either a pain flare or a fatigue flare, and they're just flattened for a week. And then they say, okay, I'm not going to do that again. So I've tried really hard to kind of educate on how people can incorporate gentle movement into their life in a way that's helpful and not harmful. And I frankly only learned that by trial and error myself, and realized that if I did a warm-up and kind of had my body go through a gentle range of motion with each of my joints, that I then was able to tolerate 5 minutes of doing a gentle walk or, elliptical or bike. And then I actually felt better, not worse. And that is so fundamental. And I actually, if anybody wants to see me there's on YouTube, you can watch me and a friend who volunteered to help me go through my 5-minute warm-up. And I encourage anybody to try that if they've struggled with exercise, because, boy, that can be a tough one. And I guarantee every doctor will tell you to exercise. So.
And just very quickly, you were saying how difficult it is for people with fibromyalgia to sleep, to get good quality sleep. What do you teach your patients? Any techniques to try and help them to relax to sleep?
I do. I think the biggest thing I teach people is to understand that in fibromyalgia, our brain, the part of our brain that regulates our kind of automatic responses to things, has switched into the danger mode, so that our fight or flight, our danger response signals are constantly going on. And that's happening day and night. And that should only happen normally when we're exposed or see any danger, right? Mm-hmm. But in fibromyalgia, it's happening all the time, even while we're sleeping. So that a huge piece of trying to get your body calmed down, your brain into a more relaxed and restful place, is trying to have some very nice kind of gentle, kind of calming activities for your brain. So this is where we've all kind of heard about sleep hygiene or sleep habits. So making sure that you're not watching, the news right before bed, something that might be stressful or upsetting, and trying to kind of have a nice ritual around bedtime. Mm-hmm. And then this is where my friend magnesium, the calming mineral, comes in. Add that in. So I do teach people about that, and there's a whole chapter in my book about that.
Wonderful. And I'm going to have to stop you there. We have run out of time.
Oh, no.
Well, we'll have to have you back. People must get your book and find out what you're sharing with us there, and watch you on YouTube. And thank you very much for being with us today and answering all our callers' questions.
Thank you for having me, Linda. It was great.
Learn more about Dr. Liptan's successful integrative treatment approach to fibromyalgia in her book, The Fibro Manual, a complete fibromyalgia treatment guide for you and your doctor, available online from Amazon. It includes key guidance for your doctor so that they can help you more effectively, clinic website www.fridacentre.com, or phone 503 206 6220. Any questions or comments you may have, please email me, Linda, Linda, at ldnrt.org. I look forward to hearing from you. Thank you for joining us today. We really appreciated your company. Until next time, stay safe and keep well. The LDN Research Trust has its own forum, which can be found at forum.ldnresearchtrust.org or via our website. The forum is divided into sections, so it's easy to navigate and find what you're looking for. You can share your experience, ask questions, keep a journal, etc. Unlike Facebook, the posts are always easy to find and don't get buried. We have a private medical professionals only section. To find out more, please email me, Linda at ldnrt.org. The LDN Research Trust has an LDN Vimeo channel. I have interviewed over 550 LDN prescribers, researchers, pharmacists and patients from around the world for many conditions. You can find the link on the LDN Research Trust website. If you'd like to be interviewed sharing your experience, please email me, Linda at ldnrt.org. I look forward to hearing from you.